Foundation y referente mundial en la transformación de la formación médica. Como líder de la iniciativa Change Method, su trabajo impulsa la ciencia de los sistemas de salud y el desarrollo de aprendices adaptativos para los retos del siglo XXI.
Buenas tardes. Thank you for having me. I am looking forward to our conversation. There's been a lot of discussion about the ways that we can improve the training of our physicians so that they can better serve our patients and communities. Some of you are leaders of medical schools, some of you are leaders of residency programs, and within those buckets, we do our best to make our programs continually better, including bringing on new tools that we just heard discussed in simulation. But sometimes we don't step back to think about how we connect the dots across the entirety of a physician's career, and that's the thing that I've had the privilege to work on over the last 8 years at the American Medical Association, where I've been the Vice President for Medical Education Innovation. We started in the same way, initially focusing on medical schools and then advancing into residency programs. But we started to see that there were common needs regardless of the stage of training, and really elevating and trying to integrate our work so that the learner's experience could become more and more smooth. So as I mentioned, what I'll be sharing with you today is partially my own work, but it's really derived from our many partners across the United States and increasingly international groups such as yourselves that invite us to come and talk so that we can learn from you and all the work that you're doing as well. So as I mentioned, the Change Method initiative was launched in 2013, and it has since invested, the American Medical Association has invested over $40 million in grants to various educational programs to advance innovation. And so I'll be sharing some of the lessons that we've learned across that effort. I've listed 2 supplements here that have described outcomes from 2 of our major initiatives, and so you could read more about the details of those if you'd like. So what I'd like to do is have us think today about systems thinking and how we can apply that to our work, and think about how we can improve the medical education system, just as we're striving to improve the healthcare system. There was a presentation earlier about that. And so thinking about how our current structures may actually be standing in our way, and how we might use the disruption being caused by artificial intelligence to redesign in ways that are aligned with what we now understand as effective approaches to education. So really thinking about a systems perspective. And as physicians, we're very accustomed to thinking in systems when we think about our patients and their medical challenges and their needs. Increasingly, we've been paying more attention to the system around the patient as well. So in addition to the organic systems, better recognition of the structural determinants of health and other drivers, as well as how the health system itself functions. And so at the American Medical Association, we've elevated the concept of health system science training so that learners get that more explicitly rather than just by stumbling through the system and trying to figure it out as they go. But sometimes as educators, we don't apply that same ability to think in systems to how we work together across the continuum of training. And so this is an excerpt from one of the papers in the supplements that I referred to, and this reflects the United States system for how a learner progresses across their career through beginning medical school, being selected for residency, and then ultimately moving on and hopefully thriving in practice. But what we understand by looking across the system is that learners drop out or slip up or have struggles at every one of those transition points because we haven't coordinated well as organizations to support those transitions in a more fluid way. So how could we go about doing so? One of the things we need to better acknowledge is the interdependence that is crucial for medical training. So we work in our educational institutions, and we tend to focus on making our programs the best they can possibly be. recognizing that ultimately the learners have to engage with that clinical health system, but very frequently as educators and educational administrators, we feel like we don't have adequate influence over that healthcare system. We have to acknowledge that the healthcare system is trying to respond most directly to the needs of the community and the patients, and so its priority is and should be the patient and how to optimize care. Unfortunately, what that often translates to in the health system's mind is that learners are a burden, that learners might slow things down, that learners might introduce concerns around safety and problems. And so increasingly, at least in the United States, and it sounds similar here after talking to some colleagues, our learners are being marginalized from having purposeful roles in the care of the patients when they're in clinical settings. They're relegated to largely observational roles, and that is because the system interprets that as being more efficient and more safe. However, I mentioned earlier, July 1st is in the US when all of our new interns begin. So across the country, there will be 38,000 people entering the health system suddenly now expected to be fully functional. And so if we've marginalized them while they're students because it's safer and more efficient, what happens in July? And there is something described as the July effect, where many physicians who are in the know would not electively undergo healthcare or have family members undergo healthcare at that moment in time because they recognize the concerns. And so there's a need for us to have stronger connections. The educators must build relationships with health system administrators to advocate for the purpose of the education and try to change that mental model that this is not a burden, this is the future workforce. And we need to work together to make sure that that future workforce is optimally prepared. And again, all of this should be informed by the needs of the community, but that's often sort of an afterthought, and it really should be the forefront of what we're doing in both settings. Many of you are familiar with thinking about improving quality within the healthcare system and this idea of the quintuple aim, so improving patient outcomes, reducing costs of care, et cetera. Well, I would argue that we have the same opportunity in medical education to apply the quintuple aim. This is particularly true in our system, but education is costly. How do we reduce the cost to the learner? How do we reduce the cost to the system? How do we improve the outcomes of learning? And we had some conversation earlier about whether we allow people to progress that really aren't quite ready. How can we make the outcome of learning better so that the patient's outcomes will be better? We have a lot of opportunity to improve equity within our educational systems and enhance the learner's experience. But it's also important to take care of all of you as well. So in the healthcare system, there's an increasing recognition of the need to support the health professionals' well-being so that they are better poised to care for others. And the same is true of medical educators. Many clinician educators in particular are very strained and they're burnt out, and that's going to result in poor role modeling to the learners that are around them. And so as we think about the US system, when learners go through all of those transitions, it ends up creating these gaps or lulls in progression. So the slope of growth can sometimes be slowed or stalled at these transition points until people kind of get reoriented, moving from one part of the system to another. How can we improve that? Well, if we think about systems thinking, and I know this slide looks cartoonish, and it is. These are habits of systems thinkers put together by what's called the Waters Institute, and they are trying to train young learners, elementary and secondary school learners, around systems thinking habits. And so this is meant to be a bit cartoonish, but we have found them very effective to remind us as educators that we too sometimes need to step back and think about some of these things. So how do our mental models about what training looks like limit what training could be? How do we create a vision of the bigger picture of education instead of only thinking about our immediate area of influence? etc. So there are opportunities for us to kind of step back and try to work together. We've been talking a great deal about competency-based education. This audience is very sophisticated in this area. And really, it's the reminder that we should start with the desired outcomes, and it's those outcomes that determine what are the best training opportunities to prepare the learner to achieve that outcome. We just heard about the power of stimulation versus classroom approaches, et cetera. And then, of course, what assessments must we have in place in order to identify that we have achieved those desired outcomes. And so this is, on some hand, very simple when you look at it and logical. But on the other hand, if we're honest with ourselves, most, quote, curricula start with the training activities first. We could have a session on X. I want a new course for 6 weeks of artificial intelligence, rather than thinking about first, what are the outcomes and what should we put in place to do that. So I argue that our traditional view of curriculum is overly static. It is sort of chiseled in stone in many ways. And how do we challenge ourselves and our organizations to become more dynamic? I also like to remind all of us that competency-based approaches do not equate with being minimally competent. I've heard this pushback a lot, that competency-based education is some kind of low bar. That is not the ideal of how we would think about competency education. Indeed, competency-based education positions us to continue to strive for excellence as individual physicians across the entirety of our career. We are never done. And if you use these models well and show that developmental trajectory and integrate how we think about growth, you can see it more in that way as opposed to a checklist of things to get accomplished so that you can graduate to the next step. When we think about what it means to be competent, it's important to think about our roles as physicians over the eras. And so there was a time in which we didn't honestly know a lot, and we couldn't intervene very much, and we were there mostly to observe and to try to support as best we could, try to support families and explain to families what little knowledge we had, and basically be there very focused on the needs of the patient. Over time, we became more sophisticated in our ability to intervene, and so we became actually more focused on those interventions and arguably maybe less focused on that patient and that family because we thought we could fix things. And we are quite successful in intervening, of course. As we think forward to the future, we are all struggling right now as educators. It is our job to envision what practice will look like in 10 years, because that's what our incoming students will face. And so we need to project and think ahead and understand what their needs will be so that we can prepare them adequately. And quite frankly, we are all at a loss at this moment because as artificial intelligence is being rapidly taken up, it is changing what practice looks like. It's going to change a lot of roles across health professions. And so we're a little bit struggling to envision what are the competencies that are needed. But regardless of the technology, there are core competencies that we have described already that will continue to remain important. I've shown here both the ACGME model as well as the CanMEDS roles. You all have your competency framework as well here in Mexico. And so when we look at these big buckets, regardless of what's happening with artificial intelligence, these things will still be important and maybe even more important than ever to have all of these dimensions of performance. Now, we discussed earlier in the morning panel that we have focused too much on medical knowledge and that expertise, and too little on some of these other very critical domains, which I would argue will become increasingly important as we integrate artificial intelligence. And so these are broad, sweeping areas that we can all aspire to, and it's important to point out that putting all of this together is actually a fair amount to ask of any one individual, right? We all know people who are very book smart but may struggle in communicating with others who may not work well in teams, et cetera. And so to expect that everyone can do all of these things at a really high level is a very high expectation. And perhaps we need to reframe the way we talk about this and understand that each person does bring relative strengths and weaknesses, and we're all trying to aspire to that high performance across all of these domains. That moves us away from a normative framing of this learner is better than this learner. This learner is different from this learner, and they each have their strengths and they each have areas for improvement, and that applies across our entire career. There are important transition points where we need to be sure someone's ready for a next level of responsibility, and this is where the entrustable professional activities have been found to be quite useful. These are the tasks that will be expected of you in your new role. Are you ready for those? I think the concern I have around the EPA framework is that many people have started to use EPA instead of entrustable professional activities. And we are forgetting the entrustable word. That is such a crucial part of that framework. It is not that you can click off a series of tasks. Across every task, there is a need to fundamentally be trustworthy, and that has all of our professionalism factors baked into it, as well as discernment, knowing when I know something and knowing when I don't, and being able to recognize when I need help. And so we can't forget that that's the power of that framework, is that it re-anchors our assessment in the readiness to care for a patient and brings that patient back into the checklist model. And so we have all these different frameworks, and sometimes we drive our colleagues crazy, those who are in the front lines who might not see themselves as professional educators, but they're the ones really role modeling and teaching on a day-to-day basis. All of this lingo can be frustrating to that frontline person who's trying to put it all together. And you'll see people be in camps of, we're a competency-focused institution, or we're an EPA-forward institution. But in reality, these are two different angles to look at performance, and they're both critical. So I'm a general surgeon. If I am observing a resident perform a process of informed consent and shared decision-making with a patient, and I decide that they are not ready to be fully entrustable, that is not helpful to the resident to hear. I then have to move from the EPA framework to the competencies to explain what they need to do next. So are you not entrustable because you didn't know enough technical knowledge about the procedure in question to honestly describe the risks? Or were you not entrustable because you communicated poorly and you scared the patient and they just left? So we have to use both frameworks and go back and forth and think about how these areas complement one another. So if we can coordinate across an entire career, it's useful for the learner. We had learners when I was an associate dean at Vanderbilt, and we incorporated competency-based approaches from the very first day of school. Learners reflected back that we had unpacked the black box of what it means to be a good doctor. Because before then, it was all in the minds of the observer, and we do have a role for the professional judgment of supervisors. But if we can explain to a learner, here's where you are, this is what you're striving for, we know they're going to get there because these are very motivated and talented individuals. And so reminding ourselves that there are moments where we need to assess whether someone has accomplished what they need, but the power of assessment is really when we move it into saying, we see this, how can we help you get to the next level of sophistication and growth? And so we've talked a little bit today about the notion of programmatic assessment, and this is the work of Kees van der Vleuten. And so this understanding that we do better if we have multiple different insights on a learner's performance. And so all those pixels coming together from different forms of assessment, different settings, different assessors, and you put that all together into a portfolio to see how someone's growing. And what we do find when you start to use these digital portfolios and gather all this data is that we have to reframe the traditional conversation about formative and summative. Because as educators, we have a mental model of what formative and summative mean. But it's been translated by learners is that formative is safe and summative could be risky for me. And in this world, every single little data point could be a formative moment, but it does contribute to a summative view of where you are. And if summative remains seen as threatening, then every little data point is resisted. But if we can reframe the summative as this is data that helps us see a trend, that helps us see how we can better support you in your growth, now we have better trust from the learners and they can receive this data in a way that feels comfortable to them. So how do we become more agile ourselves? Our systems are complex, and so we do have, if anyone's gone through a curricular revision, we know that's a big ordeal that takes a couple years, and everyone's exhausted by the time you're done. And so how do we make it that we could be more agile on a regular basis and more responsive to the evolving needs of practice? So historically, as educators, we have had a tendency to say, well, we need to give you all the knowledge that you're going to need when you go forth into the world, right? So covering everything, covering all the content. And we know that that's increasingly impossible with the explosion of information. We know that much of what we do teach becomes outdated very quickly after learners move on, and some of it is actually later proven to be incorrect. We just don't know which pieces are incorrect. And so rather than focusing solely on delivering content, increasingly we need to prepare the learners to have adaptive expertise and to pursue their own knowledge improvement and their own skill acquisition throughout their career. And so in addition to content, and actually more important than content, how do we train them in how to learn? Now, if you say to a medical student that they need to learn how to learn, they will probably scoff at you, right? These are our most talented students. That's how they got into these institutions. But we have to step back and help students recognize that they have become expert in receiving that content that the traditional system delivers, processing it, and spitting it back out. They really don't know how to self-direct their own learning, how to go about a workplace and recognize when they have a learning need and respond to it. That's what it means to have adaptive expertise. So automatic expertise, you can train someone to a certain level of performance and they will lock in at that level for quite some time. But if we want someone to continue to grow on their own, they need the metacognitive skill set to do that. And so in our consortium, we developed the Master Adaptive Learner model. This was part of the very beginning consortium back in 2013 to 2015. So to do that exact thing, to help teach learners how they will continue to learn throughout their own career. And so you can see the phases here, and I'll draw your attention to the green gear. The first thing is often skipped, of planning. So people will identify a learning need and jump straight to doing something, reading something, looking something up, taking a module, or maybe signing up for a simulation, etc. But we need to stop and plan, what is the best approach for me to meet this need, and then think about how will I know that I've met it. And so the planning, actually doing the learning, engaging in some form of assessment of whether that learning has been effective, and then adjusting practice and saying, did it work? Is my practice improved, or do I have a continuing learning need that I want to keep going through this cycle again and again? So now we throw in artificial intelligence to just disrupt everything. We were talking earlier about our assessment systems. Now there's many concerns. Initially, as AI was coming into more common use, many educators had the knee-jerk reaction of, we need to ban it because learners can, quote, now cheat on essay or some other assignment. That is a short-term view it's very natural to understand why people might react that way, but it's not useful to the competency that these learners will need in a world where they will have access to these tools. So given that this is forcing us to change our assessments and forcing us to change our training opportunities, how do we do it in an intentional way that aligns with what we would hope to see happen across the system? And so this notion of augmented intelligence, so this is a theorem of informatics from over 10 years ago, Chuck Friedman, that basically was the premise that a physician who is successful at interfacing with informational systems, this was pre-AI specifically, but it certainly applies, a physician who can use those tools well should perform better than a physician who does not use those tools effectively. That seems logical. It's actually under debate right now. When we look at it, some of you may have seen studies in which AI alone was outperforming a physician using AI. And that's because we haven't yet been trained on how to use AI effectively. We have a great deal to learn as educators about that human-computer interface, and that will be a topic of study that we must all engage in. What are the features of the individual that make them receptive to using these tools, effective at questioning the outputs of these tools? We have to unpack all that. But I am very optimistic about the opportunities that AI offers us, and so it's important that we start training. We first published through the National Academy of Medicine in the United States back in 2021 a, quote, call to action around integrating training of AI into health professions programs. And honestly, it was largely ignored that first year that commentary was out. And then ChatGPT became widely available to people, and suddenly I started getting all these calls for speaking engagements all across the country because folks realized, oh, this is a real thing, and we're going to need to figure this out. So these are some proposed buckets of competency. I won't go into the details of this in interest of time right now, but happy to take questions later. What's important to recognize is that we shouldn't take a new set of competencies as an entirely new thing to tack on to our existing competencies, but rather there's an opportunity to think about how to interweave these. And so if you look at the competencies for AI, other than the first one of fundamentally what is AI and how does it work, all the other things weave pretty easily into existing domains. And so to use AI effectively in a clinical encounter, the physician will have to have communication skills to help explain to the patient the role of the tool and how it's being used. And so we shouldn't see this as entirely foreign. Indeed, it integrates really well into many of the things that we teach around evidence-based medicine and effective clinical encounters. If you want to learn more yourself and haven't had a chance to yet, these are a series of introductory modules on the use of AI in healthcare, not specific to training. These are open access for now. If you want to use them, I would encourage you to look at them relatively soon. There's some desire to gate them behind membership, so I'm trying to publish them while they're openly available to everyone. And we would never suggest to only use the modules. These are great to use as a flipped classroom experience where perhaps learners complete a module and then you have some activity together in the classroom to really think about how this applies to their work. So if we go back to our master adaptive learner model, and in the era of AI and data, think about integrating this model from informatics, which essentially says there's a lot of data out there, but the data alone is not useful unless you process it through multiple steps to advance from a whole lot of data to some form of information and knowledge, and hopefully eventually some wisdom from that data. If you merge these two models, you get the concept that we have recently described of precision education. And so if you look at this precision education cycle, you see some of the words from the master adaptive learner model there and the big arrows: planning, learning, assessing, and adjusting. All we have done here is to emphasize the fact that every one of those steps can be informed by data inputs, and every one of those steps generates new data outputs. And so essentially precision education is competency-based education supercharged through data and analytics and artificial intelligence. You can read more about the conceptual model at that QR code. What we recognize is that this can be applied to the individual. It can be applied to a cohort of residents within a given program. What do we need to do to improve the learning across that entire group? Or it can be at an institutional level, and then it starts to overlap with the concept of the learning health system. So we posit in this recent piece in the New England Journal of Medicine that by leveraging AI and this concept of precision education, that we have opportunities to enhance competency development at every step and to smooth out some of these transitions. It's a short piece, but there's much more detail about that within that article. The AMA I've had the pleasure to launch a $12 million grant process for schools and residency training programs and continuing professional development, so across the continuum of projects leveraging this concept to improve learning and competency development. Again, I had the QR code because I don't have time to give you all the 11 projects to illustrate them, but I will pick a couple just so you can understand what it is we're talking about. There's been a great deal of discussion here around communication skills. We targeted this grant program, and we said we would not fund any projects that were around medical knowledge. We wanted only projects that were looking at other dimensions of performance. And so we have several that are looking at communication skills. A couple quick examples. So one is to take the ambient scribe technology that many of you as clinicians are using now to capture your encounter and automatically document your clinical note. There's a great deal of uptake of this in the United States. I assume that it's permeating here as well. Well, at first there was concern among educators that, well, we use the clinical note to understand the learner's clinical reasoning, so we better not let them use these scribes because the note is supposed to be how we tell if they have good clinical reasoning. So if we go back to our systems habits, that is a clear example of a locked-in mental model about how we assess clinical reasoning. Rather than the learner's note, we now have the entire encounter. It's been captured and transcribed, and so we can see whether they have logically formulated a hypothesis through their interaction with the patient. But to the point of communication skills, there's now an opportunity to provide feedback about communication. And importantly, recognizing the power of nonverbal communication is not captured in this way, so I want to acknowledge that. From verbal communication, there are elements called paralinguistics, which can be captured. So in addition to the specific words, we can let a learner know, what percentage of the time of the encounter the patient spoke versus you spoke. How many times did you interrupt them? How many times were there cues for empathy, then you kind of charged ahead and didn't respond? And so that can all be captured and provided as feedback. And we think about that as a learner, but think about that as a practicing physician. Once we're in practice, no one observes us, no one gives us any feedback. We get some information from patients occasionally from a satisfaction survey. But this now gives us an opportunity to get feedback and constantly grow our expertise in effectively communicating. Okay, so then you get the feedback, but what do you do with that if you have an opportunity to improve your communication skills? So one of the other grants is creating an on-demand virtual simulation platform that's based for phones. And so that a resident who is tasked with delivering bad news in the middle of the night without support, who really only got to practice it once in the official sim center, because that is a precious resource that is highly limited in how much practice you can have. Rather than going straight into the room, that resident can verbally describe into the phone the general case, of course not any protected health information, and it will automatically generate an interactive avatar so that the resident can stumble through their words and stumble through that conversation with a virtual avatar before stepping into the room talking to a patient and family. So that's a couple examples of what we consider precision education. So not only assessment and feedback, but then the so what of how do we help you get better in the moment, right when you need it. So many of you didn't get $1 million grants from the American Medical Association, and I recognize that there can be some frustration. The level that those projects are at is obviously quite involved and sophisticated. But there's a great deal that can be done with things that are openly available and platforms that are approachable to anyone. If you haven't seen this scoping review by Gordon et al., it describes in general the various ways in which people are experimenting using artificial intelligence. It's already probably a bit outdated because it's 2 years old, and this is a very rapidly evolving field, of course. But it is easy to dive in and start experimenting with things without necessarily needing a very elaborate system. We put together a guide because before our grantees even applied to us, we were concerned that many educators are enthusiastic about using these tools, but don't understand the technology well enough to use the tools responsibly. And so this is a very basic guide about things you should consider if you are delving into using artificial intelligence. And it's meant to be an introduction to help you think it through. And so just briefly wrap up here, we think of our learners as developing in this idyllic environment in which they're nurtured and they're growing, and we're fostering their professional development. From the learner's perspective, when they're out there in the clinical world, it often feels like this, that they're struggling, it's stormy, and they feel kind of isolated and alone. And so we need to be more aware of the systems in which the education is happening. And so we're describing in a paper that's forthcoming the concept of socio-technical systems theory, which thinks about you can't just drop the technology into an existing system. We need to redesign the entire system so that people's roles are clear, their incentives align with what we hope they will do. We've heard a lot about competing incentives around both the learner and the educator in a busy clinical system. How do we need to change our workflows? How does the technology fit in? What infrastructure do we have to put in place? And importantly, what culture do we create so that this is safe and that all that data is to support my growth and doesn't make me feel like I'm constantly under surveillance. The deliberately developmental organizational model is an important framework to think about, do you have the right organizational culture to make these tools effective? As an organization, is it clear that everyone is growing, everyone is struggling, and we're all trying to improve? Does the organization acknowledge that the status quo is not something to aspire to, that in order to constantly get better, you need destabilization? How do we lever the hierarchy so that we can all learn together? Particularly, we need some humility right now in using AI tools because many of us weren't trained in that. And so how do we learn together as we integrate something new? Coaching, formal coaching programs is a very strong organizational signal that you are invested in the development of individuals and supporting their growth. And then just reminding us that it all still remains around relationships, the relationship between the physician and the patient, but also our relationship as educators with our learners. And how can we leverage these technologies to take away some of the administrative box checking that we do and spend more time face-to-face at the bedside providing guidance and coaching? And so reminding ourselves that we're generating that workforce and how do we coordinate our work together to do so. I'm happy to take questions.
Thank you so much, Dr. Lomis, for such an enlightening lecture. We have time for a couple of questions. Tenemos tiempo para 2 preguntas del público.
Buenas tardes. Felicidades por tan excelente ponencia. Okay, thank you. Buenas tardes. Felicidades por tan excelente ponencia. Mi nombre es Julieta Herrera, soy formada en el área de medicina y en el área de educación. Y la pregunta es, ¿por qué esperar que alguien que está en posgrado no tenga esas habilidades cuando durante el trayecto de pregrado en la formación médica debió ya adquirir esas habilidades de comunicación, esas habilidades de empatía? ¿Qué sucede cuando ya está en un posgrado? Aún nos damos cuenta de que no tiene esas habilidades. Mi pregunta va en el sentido de que, ¿de qué forma o qué piensa usted, doctora, de utilizar algún instrumento que nos oriente desde que el estudiante quiere ingresar a esta formación médica, detectar, ¿verdad? Como bien decía, es un experto en conocimiento académico, es el mejor promedio, pero carece de estas habilidades comunicativas, de empatía, de acercamiento al paciente. Entonces, tendría que haber algún instrumento o alguna estrategia de detección para estos estudiantes y que reforzáramos todas esas habilidades en un acompañamiento más individualizado para no perder al estudiante, ¿no? Tal vez ni él mismo se ha dado cuenta que carece de esas habilidades. Entonces, ¿habría algún instrumento, alguna forma? ¿Qué es lo que piensa usted al respecto? Gracias.
Thank you for the question, and thank you for the voice in my ear helping me understand your question. So essentially, what I'm hearing is, as someone who's receiving a learner into a residency program, there is certainly frustration when they aren't prepared for all of the dimensions of the work that they are going to be expected to do. And so we see this tension between medical schools and residency programs, and feeling like perhaps the residency program, that the medical school hasn't done its job. On the medical school side of the equation, depending on the residency program that the learner goes into, the expectations of what they need to be ready could be very different. And so it's difficult on both sides of that equation. What I'm optimistic about is the power of competency-based thinking on our part across that continuum. Because historically, we have had what I refer to as compensatory grading. So a learner's grade in a course is what moves forward in terms of data, and we don't know what's underneath that grade. And so even in a clinical rotation, at least in the United States, the ultimate clinical grade of a clerkship is heavily weighted on the knowledge examination. You need to have scored highly on that test, and then other domains come into play. And so if you're really good at taking tests, but you're not a good team player, you will be a horrible resident, right? But that's hidden under an A or an honors, whatever grading system that you use. What we did at Vanderbilt with our competency-based system is we pulled out the competencies separate from the course grades, so that every learner had to pass all their courses, but they also had to show adequate development in every one of those domains in order to progress. And it wasn't that you have to hold them back or remediate in the traditional sense, but if someone is struggling with their teamwork, you would know that because you have that data out from underneath the grades. And you can identify that trend, and then whatever rotation that learner was already scheduled to be on, they can continue into, but you've got a coach with them that's focused specifically on how are they working with others, providing them more feedback, maybe talking to them throughout the day of, you could have done this better, you might have considered this perspective, and working with them in that targeted way. And so the whole concept of remediation changes because you don't have to hold someone back, you don't have to put them in some special course, you just pull out that missing piece and really focus on that and elevate and balance out the weighting. And so these new systems with more data and with AI interpretation, we hopefully could find those trends more readily and make those adjustments in training in real time so that the learner is actually progressing. And we saw this at Vanderbilt. We could identify the poor teamwork person in first-year classroom team-based activities because we now had that data. So before they even got to the clerkship, they were coached on how to be a better team member. I think that that is important, but then also at that transition, having a system where it's okay to be transparent, that this is an area this person had struggled with, this is what we did to bolster them, but you're going to continue to need to think about that specifically as you develop them further as a resident, when we can really have that handover in a way we haven't in the past. Thank you.
Hi. I will move away from med school and residency because you already described the transition to residency, transition to practice. And probably because of my age, I will ask you, what is the role of medical schools or associations like ours or AAMC in trying to help physicians in their pathway through the career? Because I can identify, after my own experience, that we have different phases in our practice. Early one, in which you want a lot of patients, a lot of cases, and all that. Then you become more selective because you are feeling more secure with your approaches. And then the late one, probably the one in which I am right now, in which you see the end. What is the role of medical schools? And also, how we as associations also interact with the organizations, physician organizations, in order to help them to transition the practice once already in practice in these different periods. You mentioned a little bit, and probably the use of artificial intelligence may help, how we build up our personal learning environments, the type of skills that we need to develop are not the same at the beginning of a pathway or at the end. So I would like to hear your comments on that.
Thank you for that. And it's true that as we advance through our career, the scaffolding is slowly taken away, right? So there's a great deal of structure around the training of a medical student. The resident is kind of in that odd position of being both a provider and a learner at the same time. And then you're out in practice and you hardly get any meaningful feedback and very little opportunity to understand how you're doing. And so how do we build in more feedback for the practicing physician? How do we create opportunities for them to learn? And if we're honest, most continuing professional development is performative, right? We have a requirement for a certain number of hours of training, and people often will try to get that in the easiest way possible. To David's earlier question, it's not just the students who want to avoid the hard work of learning. It's the very busy physician will tend to pick things that they're already quite good at rather than understanding that they need to build other skill sets and pursue things that maybe make them feel a little uncomfortable. And so we're hopeful that these new models will allow us to capture more data so that the physician could have a more honest representation of their performance and acknowledge better where they could devote their energy more effectively to their ongoing growth. We know that the imprinting from residency training is the strongest predictor of how you will practice throughout your career. And so what you learned coming out of practice, you will continue to do for at least 10 years, even though the field is rapidly evolving. And at the AMA, we're aware that physicians have a good intention to try to keep up with their training and keep up their development. But when we go out into the field and talk to people, they are so busy with high throughput cases and clinical work that they don't get to have the time for their learning. And they actually express moral distress because they know they should be doing better to keep up and yet they can't. So one tool, quickly as an example of where this new technology could help us, is our team at JAMA, our journal from the American Medical Association, was dismayed to see fewer people reading the primary literature because they're too busy and they focus on things like up-to-date and now open evidence. And so they created a tool that can look at your clinic for the upcoming week. And so as a surgeon, if I was going to be seeing 12 patients on an afternoon, it would look not on a one-to-one clinical decision support focus, but looking across that panel and those patients and all their comorbidities as a collective, which articles would be important for me to read before Wednesday? Which new and current papers would be most valuable if I'm going to take the time to learn, that I'm likely to say when I go in there on Wednesday, I'm glad I read that. And early pilots were very promising that in the moment the physicians remembered seeing the paper and remembered it as a resource. And so there are opportunities that we can support our growth throughout our career. When we think about the roles of our programs, it is interesting to there's a desire to keep relationships. Most physicians lock in on their professional societies, and so I think that the power for supporting this is probably going to be from profession-wide data gathering, data benchmarking, and tools, et cetera, that feel most pertinent to your clinical field.
Sam Hamdi from Dubai. Precision education is derived from precision medicine, which was personalized medicine, and the idea is diagnosis and management of a disease. It will be based on huge number of data because cancer breast is 100 types rather than one for this particular. So the same in precision education, that you are tailoring the education, the training, the intervention to an individual resident or students. But it all depends on the type of data and the quantity of the data and when the data are collected and so on. So what's your advice? How we are doing it now? I know it's still early. Which type of data we have to collect and and which instrument, artificial intelligence, is helping in do that. Could you elaborate a little bit on the data collection and then how the decisions are made in precision education? Thank you.
Thank you, and thank you for drawing that connection with precision medicine. I do want to say that I think we struggled with precision medicine because it was too focused only initially on genomics and did not take into account the larger context of the patient and other dimensions of who they were and factors that contributed to their health outcomes. And so it's our desire not to repeat that mistake as we develop precision education. And so the data has to include the context and have that, we're focusing as an organization, as we promote this, trying to say that data is not the only aspect of this, that organizational culture, the context in which the learner is pursuing their training also has to change in order to make this data useful and meaningful and allow learners to trust us. So there is, when you see that little guidebook that I mentioned that I had created, the biggest section is about data and quality of data and types of data and quantity of data. That is a very fundamental part. Everyone's all excited about the shiny object of artificial intelligence, but the real work has to happen on very boring data sets first before you can do the fancy algorithm and have it have meaning. So we do need to focus on all the data elements, but we also need to be careful that the data doesn't become a threat. And that's why we've put a great deal of emphasis on responsible design, humility about what we can say as we apply these new tools, and then making sure that there's always that so what for the learner of, we have the data now, what are we doing differently to help you get better? And so our collective is working together across all the grants to really think about how do we do this responsibly and in a trustworthy way.
Thank you.
Thank you so much again for your amazing talk. Here's recognition. And also, please give a great round of applause to our lecturer. Thank you so much.
Agradecemos a cada uno y cada una de ustedes su permanencia. Hacemos un pequeño receso para regresar con las actividades que están programadas a partir de las 3 de la tarde con algunos talleres y una mesa que se presentará.